All right. I know that there are still people joining us, but for the sake of time, I would like to go ahead and kick us off and get us moving because everybody has important places to be. So I'm going to start our meeting. Today, we are going to discuss the health maintenance activities and the nurse assessor and the interaction there. My name is Candace Bailey. I'm the HCBS Division Director. Today is Tuesday, April 29th, which means it's almost May, which for those of us that live in the world of kids means school's almost out, which is weird and hard to think about. And I appreciate you all joining us today on this Tuesday morning to get a little bit more in the weeds of the HMA, health maintenance activities, and nurse assessor and how that's going to work and interact together. We're really excited about this. Next slide, please. All right, so the slide, obviously we forgot to update. It says 10:30, but we're going to start now. Just as a couple of reminders, we are recording, so please avoid sharing any protected health information. Use the chat feature. We will do our best to get to the chat, but I will note that things that are just commentary, we're not going to respond to, because if it's not a question or not things that we need to respond to, we may not also have time to get to everything. The slides are posted. We did make a slight tweak to one of the slides, just the wording was a little off and confusing, so we changed it. And so we are going to get those reposted with the correct wording on the one slide that we changed. If you are listening by phone, please press *6 to unmute your line. Closed caption is available for those of you who would like to have the closed caption. Please turn that on versus using an AI reader. A lot of those get posted to the internet and cause a lot of confusion and problems for us moving forward. And again, more information, we have our nurse assessor website, so you can please go to the website for all kinds of information, from the assessment tool to the slides to previous stakeholder engagement. All of the things are posted. Next slide, please. All right, so we always like to ground ourselves in our mission, which is improving healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. Next slide, please. Okay, so today's meeting purpose is really to get into the interaction and really engage with you all and communicate and discuss the health maintenance activities and nurse assessor project and how that works together. Next slide. Here is our agenda. We're going to go through a little bit of the background on the nurse assessor, and then we will review the skilled care acuity assessment, just a little bit there. And then we're going to go through the health maintenance activities, the nurse assessor recommendation, the case manager process, all of those things. And we're going to get some case examples to help put it in some real world terms for everybody. Next slide, please. Just a quick little recap from the last meeting. We did an overview of the actual acuity assessment and development process. So that was a really deep in the weeds review of how the assessment was developed, going through the assessment and all of those. And that information is all posted. It was recorded and the slides are posted on our nurse assessor website. Next slide, please. All right, so we're going to go through a little bit of background here for everybody, just to give everybody a place to start and kind of how we got here and where we're going forward. So in 2024, so last year, during the legislative session, we put forward a budget request that would ultimately allow us to provide one assessment for all of member skilled care needs. And the idea is one-stop shop. So you go to one place, you have one assessment to have that individual assess you for all of your varying skilled care needs from all the different levels, whether we're talking private duty nursing, CNA services, health maintenance activities, skilled care. And you can get it all assessed in with one tool at one time, instead of having to go to some different agencies. The initiative was developed and outlined so that it would actually align with many other key initiatives, such as Community First Choice and the pediatric PAR resumption process. And a lot of that was based off of some pretty key stakeholder feedback, which we appreciate you all sharing with us as we were going forward with this. Next slide, please. All right, in the budget request, some of the things that we agreed to do was to end the utilization review / utilization management, so URUM process, that currently exists for health maintenance activities, which reduces the appropriation. So the process that currently happens where the case manager does their assessment and then sends the paperwork over for utilization management review to Telegen on the back end, they request information. That process is going away. So that will no longer need to happen. Instead, what we are going to do is we're going to hire a clinical third-party nurse assessor to conduct the acuity assessment for any member for all skilled care needs. And so the difference here is the assessment and review is happening on the front end by a clinical individual for all of the clinical services. Next slide, please. All right. In addition, one of the things that we really wanted to ensure and that we committed to was assessing members in a holistic manner. And so right now we know that if somebody needs private duty nursing and they also need long-term home health and they need waiver services, they have to go to 3 different places to have their needs assessed often, because a lot of private duty nursing agencies don't also provide long-term home health services. And so this is really to help make sure that one member can go to one place for those skilled care needs instead of having to go to those 3 different places. It's really going to promote member choice by engaging the member and the family to help determine their preferred method of receiving services. And so it will provide, this nurse assessor is going to provide education on the front end to say, hey, it looks like you need assistance with these varying needs. Here are the different ways you can get those needs met, whether it's a private duty nurse, whether it's a CNA, or hey, there's this other really cool new option that is available to all members now, not just adults, that will be self-directed options, just in case that is a better way to meet your needs. And they're going to provide that education on the front end so more members can understand all the various ways that they can actually get their needs met instead of just the one way that that agency provides services. Next slide, please. So really, our overarching goals with all of this is to improve the clinical support for case managers. So right now, case managers are assessing for skilled care needs, whereas I would venture to say 99.9, I'm sure there's a few clinical folks out there in the case management realm, but most case managers are not clinical staff. They don't have a nursing degree, and they don't necessarily have the ins and outs and the training to assess for those skilled care needs. And so this is really to provide that clinical support for those case managers, help them determine the different levels between the skilled care, because there are a variety of different levels that are available. And, that difference between what is considered clinical care and non-clinical care, otherwise skilled care and non-skilled care. We really are hoping to increase the awareness and self-directed services, hence the education piece on the front end. I think there are a lot of members that perhaps don't realize that they can actually direct their own care and their own services, and they can have somebody they choose of their choosing to provide those services, even if they aren't a nurse. And so that's the really exciting thing, is providing that awareness and education up front, so an individual can make that choice how they want to receive their services. We want to minimize duplication of services and conflict of interest. So there is an inherent conflict that exists when I am a private duty nursing agency and I come out and I assess you, provide an assessment for private duty nursing, and I tell you that is the only way to get your needs met. That it creates a conflict of interest. And so this actually removes that conflict, even if it's a perception of one, it removes all of that. And so that all of the various options are available to a member. And then it really ensures that members are receiving services at the appropriate level to meet their needs. So making sure that somebody that needs a nurse to come in and conduct a certain level of care is assessed for that nursing instead of having a CNA, or vice versa. When you don't actually have that nursing level of care, that all those needs can be met with a CNA, making sure that that is what has happened, what is authorized going forward. Next slide, please. All right. So just a little update on Community First Choice here for everybody. Beginning in July 2025, many services, including CDASS and IHSS, so Consumer Directed Attendant Support and in-home services and supports, will be moving over to Community First Choice, or CFC, which is a state plan program, rather than being available through our home and community-based services waiver. So they are going to be moving out of one program and into another, so it will be available to more individuals. Members can switch to CFC at their continued stay review. So if you are on a waiver at your continued stay review, also known as your CSR, you can switch over to CFC starting I think they're starting the assessments May 1st-ish. I may have made that up. They're starting their assessments soon, sorry. That team has the details and everything, the CFC team, but all the transitions will be completed by July 1st of 2026. Individuals, members can actually maintain their waiver enrollment and also be enrolled in CFC and also have long-term home health and also have private duty nursing. So you can maintain all of those different options if that is what you need. The implementation of the nurse assessor is aligned with the start of CFC to really help make sure that there is a continuity and a continuity of services, that it's streamlined so folks have those options and those choices all at the same time, available at the same time. It should make it easier for everybody. Next slide, please. All right, QD assessment. So a little overview here. Sorry, I just want to make sure. Okay, so the Healthcare Policy and Financing Office of Cost Control and Quality Improvement, also known as CCQI, that's where our clinical team lives, contracted with For Health Consulting to develop a proprietary, and by proprietary we mean Colorado owns it, so it is a Colorado specific tool. It is not owned by anybody else. Evidence-based assessment for skilled care services offered to the state's Medicaid population. And so we had a consulting agency, or actually it was they're a subset of UMass, University of Massachusetts organization that created this evidence-based tool for us. The resulting skilled care acuity assessment, also referred to as the acuity assessment from time to time, to shorten it because that becomes a mouthful to say, was actually finalized in October of 2024 following extensive testing and piloting with home health agencies. So to be clear, while home health maintenance activities was not specifically piloted, we did evaluate how the assessment could be utilized for health maintenance activity. Keep in mind that this tool is for skilled care services. Health maintenance activities, by definition, are skilled care services. And so there is that piece that is really closely aligned, and we want to make sure that that is clear. Next slide, please. Okay, continuing on our overview, the intent of the skilled care acuity assessment really is to provide an objective perspective to determine the appropriate service tasks and hours for members that need skilled care. Private duty nursing and long-term home health assessments feature questions that are designed to help the nurse assessor, determine the appropriate level of support needed from a private duty nurse, certified nursing assistant, or intimate nursing visit. So really designed to help the nurse assessor understand and get at what level of skilled care, again, skilled care services. The project was funded through ARPA, our initiative 6.01. And there's a link there, and I'm sure somebody else can post that in the chat too, so that everybody can take a look if they would like. Next slide, please. Okay, so one of the key things for everybody to know is that this tool is valid and reliable. And what that means is it was tested and found to measure what it was intended to measure, which means an individual's skilled care needs, and it produces consistency and reproducibility of the results over time. So once a tool is found to be valid and reliable, you no longer make changes, because then you compromise your validity and your reliability of the tool. You lose that valid and reliable piece of it. It was piloted on tasks and nursing interventions outlined in the tool. Again, while this was not specifically piloted for HMA, that does not make it invalid or unreliable tool for the HMA population, because HMA is still skilled care tasks, which is what the tool measures and reviews for. Next slide, please. All right, I promise we're going to pause for questions here soon, mostly so I can probably stop talking for a second so you guys don't have to listen to me nonstop. All right, scoring and assessment. All right, so the assessment measures a member's need for skilled care. This is a member's functional ability, type of assistance, and frequency of intervention and tasks. Again, skilled care, all of those things. Using a systematic conditional logic, the assessment calculates the hours and time needed for care. This assessment also has a section that allows for the nurse assessor to provide a summary of any additional information that may impact the member's daily skilled care needs. So the assessment is not a time for task assessment, to be clear. It uses a systematic conditional logic, which is a little bit different, but it does calculate the hours needed based on the frequency of the interventions and tasks. And then as stated here, there is that additional section to where perhaps it doesn't fully capture the amount of time or, what have you. The nurse can actually add that additional information into the assessment to help account for that. Next slide, please. Hey, look, there's the link for the assessment tool. So we will post that in the chat so everybody can see it. You can actually download this tool. It will have to be downloaded. You can download the tool to go through and walk through it yourself, just to get a feel for it. There is a lot of information on the website as well. There's a video that will help teach you to learn how to utilize the tool, how to walk through it. So there's a lot of pieces of information to help assist with this as well. All right, let's move on to the next slide, please. Acuity assessment in HMA. All right, so while the acuity assessment was not originally built for health maintenance activities, it was designed to identify skilled care needs and is grouped by traditional service type. The assessment determines the frequency of skilled interventions in the various body systems. It is actually more comprehensive than the CDASS task worksheet or IHSS calculator. And if a member is determined to need skilled care services, they can receive those services through HMA and CDASS or IHSS. All right, next slide, please. Let's go through this piece because I think this will be very helpful. So just as a reminder, here's the definition of health maintenance activities. It's skilled health-related tasks that are normally provided by a nurse or nurse aide, which is exactly what this acuity assessment is doing. It is measuring nurse or nurse aide tasks. The difference here is it's instead provided by an unlicensed trained attendant. HMA is available in IHSS and CDASS. Next slide, please. These next couple of slides are really good examples to show how well this lines up. So here is a list of skilled tasks that are in the acuity assessment. So there's the CNA, the brief or standard nursing, and the PDN. There's a lot of lists. I am not reading all of those. Nobody wants me to read all of those. The point is there's a lot of things that it goes through. Next slide, please. Health maintenance activities. All of the tasks that were shown on the prior slide can actually be performed in HMA with a small exception, and it's those tasks requiring nursing assessment and judgment. The most relevant example of that would be complex wound care, which requires a high level of nursing judgment and treatment. Everything else in there, aside from the things with nursing judgment, can be provided at HMA. So those tasks are the same. Skilled skin care, including simple dressing changes or application of prescription medicines, can also be done in health maintenance activities. These are all things that this assessment is assessing for. Next slide, please. So here are the skilled tasks in HMA. The lists are almost identical, as you can tell. There are a couple of things that this tool assesses for that cannot actually be provided in HMA, but that's it. The point of showing this slide and the slide two slides ago was to really show you the alignment that it is skilled care. What health maintenance activities does and provides is skilled care for members. Cassie, feel free to jump in and let me know if you want me to pause and answer any questions. I know the chat, there's a lot happening in there. I clearly cannot do the slides and the chat at the same time. So just let me know if you want me to pause at any point.
I think the big questions are, how can you know this tool is valid and reliable if it's not been tested on anyone using HMA? I think that's kind of the big theme at this point, which you did speak on. I don't know if you want to address that again.
So the reason why we know it's a valid and reliable tool is because the tasks that are being assessed for are the same. It is the same tool when you're talking skilled care that was tested and is valid and reliable and found to be consistent and measures what it needs to measure, which is the same type of care, excuse me, that is provided in health maintenance activities. All right. Any other questions you want me to jump on, or we want to keep going and answer questions in a little bit?
Nope, I think we can keep going for the moment.
Okay. All right, next slide, please. Okay, so here's one of the key areas that I know everybody's super interested in is the scoring versus current authorizations. So here's how this looks. So the nurse assessor is going to complete the skilled care acuity assessment, followed by, and for those that are also receiving personal care and homemaker, they will also do the direct care services calculator to capture any of those unskilled needs that were identified within the discussion of the assessment. So for all of those services, the nurse assessor is going to conduct the assessment and the direct care services calculator, which you all know is going to be used for CFC, for personal care and homemaking going forward, to determine and make sure that those needs are also captured. If the identified need of the skilled services is actually lower than the current authorized hour, so if a member, the needs that were assessed for is lower than the current authorized hours and is within a 5% variance, the nurse assessor will move forward with the recommended hours. So they will send the recommendation letter to the case manager for them to use going forward. If the scoring in the recommendation results in a 6% or greater decrease in services, so if the variance is higher than 6% or higher, then the nurse assessor will complete the health maintenance portion of the direct care services calculator. The results from that will be included in the recommendation letter, and then this will be provided to the case manager as for additional context around frequency, scope, and duration for the case manager to complete the authorization. Again, one of the things that's key is these are recommendations. Next slide, please, because that gets more into the recommendation. So the nurse assessor completes their assessment, and if necessary, also the direct care calculator. And then they put all of that together and they provide a recommendation letter that will go to the member, their family, and then also the case manager, and then if the home health agency is involved, to the home health agency as well. The case manager is still responsible for providing and completing the prior authorization. They are going to receive the nurse assessor recommendation letter through the Telligent portal. It's the same portal that they've been using, which is nice, so they already know how to use it. And they are going to use the recommended hours to develop the service plan and the prior authorization. Now, again, this is a recommendation letter, and I'm hounding on this word because it is just a recommendation. If there are tasks or there is time that is actually not captured in the assessment or the recommendation, the case manager has the authority to adjust the authorized hours. If the case manager says, hey, it looks like we're going to need an extra hour for the BOW program, and here's why, that's allowed. The case manager will have that information. All they have to do is make sure that there's clear support and justification on that additional time. And then they can authorize the hours and everything goes forward.
And it's going to be a pause for, I think this is a good breaking point. Can we pause for Laura, who has her hand raised?
Absolutely. Laura, go ahead.
Thank you. A couple questions about what we're talking about with the assessing tool. With HMA tasks, they're in just approaching HMA is the way that it's built is that it's a consumer-directed program. The Nurse Practice Act has been waived. We're now asking assessors to assess those tasks because they're the same tasks as skilled tasks, but are they approaching them when it comes for HMA as they need to be approached as the consumer-directed program that it is that it's not within best practices in how it's completed, it's consumer-directed. And the HMA tool, I believe, does that. And so the only time they're going to be referring to the HMA tool now is if there's a variation, a certain percentage in the hours, and that's for existing clients. What about new clients coming in? And are they going to approach this HMA tool with that, keeping that in mind that this is kind of outside of what the scope of practice is? Yes, I understand about getting it all in line. And I appreciate that. And I want to do that as well. I just want to make sure that the nurse assessors are going to be approaching the assessment with that in mind.
So thank you for that question, Laura. So they are absolutely going to be approaching this with all of the different components in mind. The key here is to outline and identify the tasks and the services and the care that is needed that is considered skilled care. And it says, hey, you have a ventilator and you need assistance with your ventilated care. And I'm making these up and I am not a clinical person, so forgive me. Here are the 3 different ways you can receive your care. And the time is, and the time for task is actually, it's not a time for task assessment. I hear what you're saying, they don't follow the recommendations. However, skilled care is still skilled care.
Right.
And
right.
health
I
maintenance,
totally get that.
health maintenance activity.
Okay.
Health maintenance activities still must be skilled care services.
No, I totally
regardless.
understand that. But I think as soon as the member identifies, I want to go with IHSS, and I think there should be the, okay, well then let's plug it into the IHSS calculator to then determine the amount of hours, because we can't use the point system in determining the consumer directed program hours based off of points versus what we've always done, which is frequency and duration. And I understand there has to be guidelines, there has to be limits and justifications. I'm not saying there doesn't. And I think if as soon as the nurse assessor has identified the need for the skilled care and them saying, as a member, I choose IHSS, okay, cool. Well, then we need to have a frequency and duration figured out to determine the hours.
Right. That's what the tool does. The tool actually looks at frequency and duration as well. That is part of the calculation, is the intervention time and the number of times the intervention occurs. So frequency and duration is absolutely part of the tool as well. And it needs to be as consistent as possible across the different modalities, because it's still skilled care. If we are finding, and if the member is expressing that this time is not meeting their needs, is not able to meet their needs, there is no problem with the case manager authorizing additional time, and the direct care calculator can be completed as well to make sure that the member is getting their needs met. But the frequency and duration is actually part of the calculation as well.
Okay, and just to clarify, is the agency's assessment of the needs taken into consideration on either side, the case manager and the nurse assessor?
The nurse assessor can look at any information that is provided to them, and the case manager obviously absolutely looks at all of the information as well. So I would say yes, and you can provide it to both sides. And again, it must be, sorry, I'm trying to organize the thoughts. It must be in a way that the case manager and or the nurse can justify those hours as well, if that makes sense.
Perfect. I just wanted to clarify that it's still an expectation that agencies are assessing their clients.
Yes, absolutely. Absolutely. As an agency that's providing the care or is responsible for the care, absolutely.
That's a question I get a lot. So I just want to make sure that's what you guys want us doing.
Yes. Great. I'm glad we clarified that. All right. Looks like Alyssa is next.
Hi, I'm a nurse with an agency, and I'm just wondering if this change makes any changes to what my responsibilities are within the agency for these IHSS clients.
I'm not sure I understand your question.
So currently, when I receive an IHSS referral, I go out and I do my assessment. Sometimes there's a lot of variation with HMA because I am clinical and many of the case managers are not clinical. And so there's some back and forth me explaining and a lot of good conversation that goes between what the rules are with that the case manager understands and what the clinical needs are that I understand. And then we come to an agreement, it goes to Telegen. So I'm just wondering, am I still going to be doing my job as a nurse within the agency and then also validating the skills and doing the 90-day visits to reassess? Or
Okay.
does all of that go to this new nurse assessor?
No, the nurse assessor is not doing the reassessments or any of the oversight, but I'm going to go ahead. I see Erin has her hand raised, I believe, to answer your question. So I'm going to let Erin Thatcher answer your question directly.
Okay, thank you.
Thank you, Candace. Hi, everybody. I'm Erin Thatcher. I'm the Participant Directed Program Supervisor. So in a nutshell, we are not changing any IHSS agency requirements. So your agencies will still need to be licensed by the health department, certified. You'll need to conduct care planning with the member and family. You'll need to do skills validation. You'll need to provide a care plan to the case manager so they can authorize the hours. You can communicate with the case manager and member. If the member is open to it, you can participate in the nurse assessor assessment, but that's up to the member. But otherwise, everything's pretty much the same. And I just want to mention that, like, right now, case managers have to justify everything and send it to Telegen. That part of the process is ending. Like, we are no longer going to be having Telegen check our work at the end just to make sure there's no duplication or that the care is skilled, because that is one of the major things that happens, right? It's like, is it skilled? Is bathing skilled? And it depends on a lot of things. But essentially, we're doing that on the front end with the nurse assessor in that recommendation piece. And then the case manager should provide the nurse assessor recommendation to an agency if they're involved. Does that answer your question?
Yes, thank you so
Okay.
much. I really appreciate that.
Yeah, you're welcome.
Thank you, Erin, and thank you, Alyssa, for that great question. Looks like we have Anna with your hand raised.
Hi, thank you. Just a procedural question.
Sure.
So for clients who have HMAs in the IHSS program and also have personal care and homemaking that our agency provides, I understand the nurse assessor does just the HMA part. We still do all the unskilled personal care and homemaking, and we put all of that together into a plan of care to submit to the case manager. That's still going to be the process.
Yeah, so the plan of care is going to have to encompass all of the services that you guys are authorizing and overseeing and providing. And then the nurse assessor will do the HMA portion. And also, if identified any of the unskilled needs, they will also do the direct care calculator for the personal care and homemaker portion as well, to make sure that the process itself is just a little bit more streamlined for each individual member. But as an agency, all agencies should have a plan of care for all of the services that they are providing for each individual member.
Understood. And sorry, one more follow-up.
Sure.
We have a number of IHSS clients who are in the program for the self-directed care and actually don't have any HMAs. What does the procedure look like for a nurse assessor when they don't really seem to need skilled care, or do we have to do one anyway to eliminate it? I'm kind of wondering about that.
Yeah, no, that's actually a really good question. And thank you for asking that. So if you do not have an individual that is in need of skilled care, they don't have to be assessed for it. This does not have to go to the nurse assessor. So if they're just receiving personal care and homemaker, then that process, again, personal care and homemaker is going to, in IHSS and other services are moving over to CFC. But you do not have to get the actual assessment conducted by the nurse assessor if it is unskilled needs, and there is no need for an assessment for additional skilled care services. So that process would be the same. Yeah, of course. Great question.
Thanks for clarifying. Thanks.
Of course. Megan.
Okay, I really appreciate the addressing if there's a really significant discrepancy between the new assessment and the traditional IHSS CDASS worksheet, and incorporating both of those when that change potentially happens. My question is, when I think Laura touched on it amidst other things, so it maybe got missed, is if there's somebody who is new to the program, do they have the opportunity to get evaluated via the task worksheet for HMA piece, or is it only for those that are existing? And is that kind of dual process just for like this first year to be phased out, or is that going to be an ongoing part of the process, is part one of my question.
Thank you. I absolutely did miss that. And my apologies, Laura. And thank you, Megan, for bringing that up. So if a member in the discussion feels that perhaps the assessment isn't meeting their needs, they absolutely can get the direct care calculator completed for the HMA portion as well. And I would say, I don't actually know if we want to do this ongoing. I hadn't thought about that question, full disclosure, around whether we're going to do this forever. I was just like, yeah, this is just how it is. This is what we do. And it's like, wait, was there going to be an end? I had not anticipated there being an end to that piece of it, unless we identify that there should be, or it's not necessary down the road. But I think for now, this is the process until we regroup as a community, discuss it, see how it's working, and see if we need to make that change or not. But they absolutely could get the HMA portion as well if they wanted to request it.
Okay. And then with that, from at a HCPF level, is there any process going to be done to compare those two results from each other? It seems like the goal would be to not need to have two assessments. So if there was some formal comparison of this is what we got on the HMA work, the direct care, this is what we got on the school tool, how can we modify the tool or come up with some other thing to unify these at some point?
Yes, so we absolutely are going to be reviewing assessments results across all of the different benefits, including HMA and the direct care calculator and the use of that versus and with. I just want to be clear. I think I saw a comment pop up. I'm not trying to follow the comments because I'm not very good at that. I'm sorry, everybody. But I happened to see this one. The tool will be used with, or the calculator, the direct care calculator will be used with the acuity tool, not in place of the acuity tool. So I think I saw a question of how do they request it instead of. It's not an instead of, it's with. But as far as that data capture, yes, we will be monitoring. We have a lot of different data points and a lot of things that we have to be monitoring in addition to making sure all of our home health agencies submit PARs. So that is also data we will be pulling on a monthly basis, which is going to be super exciting. But actually, if anything goes the way that the therapies has been, there, it's a really good indicator that agencies are really on board and working really hard to be in compliance, which is awesome. Cassie, did you want to add on to that response?
I don't. I was going to flag a couple of things for you to talk about that I've seen in the chat.
Okay. Well, we'll finish. As we say, let's
Yes.
Megan finish the
You're
question.
good. You're good.
I you have more.
Part one turned into a two-parter in and of itself.
Okay.
My other question is about PDN, like the combo of long-term home health and PDN to equal HMA hours, and how does that work? Because a lot of times the skilled nurse and PDN are sort of combined, right? There's a lot of overlap. If you're doing PDN, there might be some skilled nurse visits that are kind of encompassed in that PDN piece, and the skilled nurse part of the calculator comes out with a number of visits per day, not a number of hours. So I'm just trying to figure out, like, how do these kind of three pieces of the assessment add together to equal an HMA hours?
I'm going to let Cassie answer that one.
Actually, if it's okay, I'm going to hand it over to Erin, who's kind of created a crosswalk.
Look at us. We're like, it's you. It's you.
We're passing the buck, but Erin has really worked hard on kind of crosswalking it, and so we can see that translation when the nurse assessor is doing that assessment.
Thank you, guys. And also, I just wanted to say thank you to everybody for your great questions in the chat. Like, there are probably things that we haven't thought about or we might have missed. So we appreciate just, again, putting your questions in and like letting us hopefully answer them. I will say, when it comes to like the recommendation, we've got a couple of examples in the end of the presentation to give us an idea of what this might look like. But in an ideal state, once all the tools are completed, we've got information in many places, like, for example, bathing as an ADL, or what kind of medication needs to be completed. And that helps inform what the HMA part of the calculator looks like. So what we'd like to have, and again, we haven't essentially developed the recommendation letter yet. We're working on it at this point. But ideally, the recommendation letter would have some options. So it would be like, you qualify for this amount of nursing in private duty nursing, but you could also have this in a different delivery option like HMA and CDASS or IHSS. So we want to have some potential scenarios for folks, as well as where to go once this recommendation is done, information for a member or their family to take this and kind of go either get the services they have and they're happy with via home health agency, or maybe getting into CFC. So I would just say this, if there are things that people think would be helpful for the recommendation letter, we'd love to hear that. We want it to be as simple as possible, but like have the outcomes available for members to use to figure out what services might look like for them. And then the other thing I'll mention is that, yes, like right now, private duty nursing, home health, intermittent nursing, CNA, and HMA are all paid in different ways. So there's, 15-minute units, and then there's brief visits, and, there's a lot of inconsistency, and we know that when it comes to how services are delivered, the nurse assessor doesn't decide that. The member gets to decide how they want their services and how it's provided. And then the agency, if there is one, or the member who's, directing their care in CDASS, gets to decide how the tasks are performed, who does those, make sure that people are trained to do the skilled care, so on and so forth. Thank you.
Thank you, Erin and Megan. I hope that answers your questions. And I can see a tiny little head and looks adorable. Oh, look at the little one. So cute. Thank you for bringing some joy to the meeting. We do love puppies and babies and kittens, just to be clear. Okay. Cassie, did you want to go through a couple of the comments in the chat to walk through a little bit here?
I do. First, let's talk a little bit about what if there is a change of condition or a reason that a member has an increased or decreased need for skilled services in the middle of their certification year. What happens? What needs to happen? What does a case manager do?
Yeah, the great question. So if there is a change in condition, let's just go with a member needs more hours, needs more skilled care. Let's say they had a surgery, or for example, because that happens often, they will do a referral to the nurse assessor, and the nurse assessor will conduct a change of condition assessment. And so the idea is, one, it's a shorter time frame to get out there and things like that. So there would be a new assessment that would be conducted to assess for the new needs and the changes in the frequency, scope, and duration, and all of the things that would be necessary. And then the nurse assessor would provide the recommendation back to the case manager for those. So that is how you would address, just like now, a change in condition for skilled care needs with a home health agency. They would come out, they'd conduct a new assessment, a new plan of care, all the things. Same idea, the nurse assessor would conduct a new assessment to help determine the new needs in the care. What other items, Cassie?
I think we'll talk about this when we get to some case examples here, but I think there's just a few other questions about like the case manager. If we could just reiterate again that the case manager is not completing the task worksheet anymore, specifically for HMA, and do they need to do the task worksheet, the direct care calculator, services calculator, if they have unskilled needs? So I think there's just a little confusion there of when they and do they not conduct that portion of the assessment.
Yeah, thank you. So just like Cassie said, case manager will no longer complete the direct care calculator for health maintenance activities going forward. So starting July 1, I guess we could say. And if an individual, if a member has skilled care needs and unskilled care needs, so personal care and homemaker and HMA as the for example, the nurse assessor is going to complete the direct care calculator for all of those tasks. If a member doesn't have any skilled care needs, the case manager is still responsible for the calculator for the personal care and homemaker, separate and apart from the nurse assessor. So there is going to be that line. It will be very clearly outlined. We'll make sure everybody has the training. It's all posted online as far as the if this, then that decision tree for case managers. All of that information is still being built so that it can be posted, but that is the process that is going to work going forward.
Great. And I think making it explicitly clear, I think Samantha Winters asked the question of starting May 1st, right? Because the old Telegen contract for HMA reviews is expiring, and this new contract with Telegen to conduct the nurse assessment doesn't begin effectively until July 1st. We're really looking at members with certification dates of September forward. So for those, that you're going to be starting work on next week for members with HMA, you're going to be using that existing HMA process. We cannot be using the new assessment tool because we don't have the nurse assessor to do that. So for these next couple months, so for members with June or July and August certification dates, you're going to be going through the exact same process you are right now. For certification September forward, you'll begin making those referrals in very late June to early July to that nurse assessor and getting that process started. So I know we're giving you kind of two different processes, but it's really status quo until you start seeing members with September forward certification dates.
Thank you for that, Cassie. That's helpful. All right, we have a question.
Yes, so I have a question. So you say that for right now, if the client will have like change of conditions, it will need a referral. So basically, how long is it going to take from putting the referral and asking like for assessment?
So there are timelines, and the timelines will all be posted online. And I don't remember off the top of my head, my apologies, exactly how long Intelligent has from the time a change of condition referral is submitted till they have to go out and complete the assessment. But they're really short, from anywhere from 24 to 48 hour turnaround times, and they have a few days to get the assessment. Now, the timeline to get the assessment completed also depends on the member's availability, and so that's a big component of it too. And we will post all of that information online with a very clear change of condition. Intelligent has this many days, those types of things. I don't have that off the top of my head. Cassie, do you have that?
I don't, but one of the things that we've promised to discuss at the next stakeholder meeting, which I believe is May 13th.
Yes.
And I have another question as well. So for
Okay,
example, if you
let her finish her statement though really
Can I
quick.
finish my response here? We're going to have a timeline breakdown of here's day one, here's what's going to happen by day 3, here's what's going to have happened. So we're really going to break down what that timeline looks like and what the time lapse between each stage of the process will look like. So we will have a visual for you developed by the May 13th meeting. So hopefully that gets to your first part, but go ahead with your second part of your question.
And the second part is like, for example, we have long-term health care, like a certified nurse assistant and a registered nurse. So for example, if the client has like, it's taking like 3 times a day the pills. So 2 times, for example, is done by a registered nurse and 1 is done by the personal care, either like health maintenance or like personal care. How is going to be that? Like if they're going to deny it, so right now it's not going to be the Intelligent, who is going to decide that if the client can have that type of task or not? After the assessment with the nurse that you have it?
Yeah, so the assessment is going to determine what level of care, of support. Level of care has many different meanings in our world, as most people know. What level of support is necessary for the need. So whether it's a certified nursing assistant, an RN, or not, or personal care, the assessment's going to be able to help determine. The nurse assessor will have all of that information for the needs in the recommendation letter.
Gotcha. Thank you.
Of course. All right, Cassie, were there other chat questions?
The last one I was just going to, I've seen a couple times, is about when and how will we determine if the assessment is going to be in person or virtual? And I was just going to say, all assessments are going to be conducted as what we're calling face-to-face. That's either going to be through a Zoom, FaceTime type of platform like we're using now, or it's really going to be done in person. How that criteria is developed is going to be something we're going to ask you about. One of the other things that we're going to talk about at the next meeting on that 13th is what is the criteria for in-person assessments? When do we think that's really necessary that happens? And then what is that criteria also when it comes to when you need an expedited, a really quick turnaround of review? So we'll have a few different things that we're going to seek your feedback on to help us make sure we have that right criteria developed. But that is one of the things. It's really going to be about the acuity of that person. is there a nurse in that area? Are you really rural? Do you have technology available to do that? So all of that will be something that we discuss, but regardless, face-to-face is how that assessment is always going to take place.
Thank you, Cassie. So just a nice little plug for our May 13th meeting where you all can come and help us determine the criteria for those, the express and for the in-person versus virtual assessments. So please come and provide us your ideas and your input at that meeting there while we are developing it. All right. I'm going to take the hands that are raised and then we're going to move on so we can get through the slides and hopefully have time for more questions after that. Looks like next up is Pat. And Pat, I believe your question was around members with intellectual and developmental disability. I happen to see that one pop up in the chat too.
Yes, that's one of the questions in my follow-up specifically, and I don't usually get personal at these meetings, is for our son who has type 1 diabetes. I looked at the tasks listed under those cares, and that is wholly inadequate for people with IDD. You have a level of supervision and a level of care that is not the same as a neurotypical person with diabetes, type 1 diabetes especially. And I hope that that will be specifically addressed and improved. I want to know for all the people with IDD and on the nurse acuity tool, those things are normed for neurotypical people, and the time that it takes often for people with IDD to receive the same amount of help, its level of help requires more time. How is that going to, how can we make sure we continue to meet people with intellectual and developmental disabilities?
Sure. So a couple of points there. Thank you so much, Pat, for raising that. The assessment tool is piloted on individuals with disabilities that currently exist within the system. So it was not actually normed to specifically or only piloted on individuals as neurotypical. That wasn't how the population was selected by any means. And so the sorry, I was reading, my folks are adding some notes in there for me to make sure I hit on. So that piece in particular was not just for one specific population. It was to meet the needs. It was adults, it was children, for the entire, that all have disabilities. Additionally, one of the requirements of our contract for the nurse assessor is that they will have staff, they will have nurses that have experience in working with individuals with intellectual and developmental disabilities. It is really important that they understand how to conduct those assessments for individuals of a variety of different populations, and that is one of the requirements. Additionally, to add on top of that, to get to your point around the time for type 1 diabetes specifically, just as the example, those types of tasks, that information can actually be added onto by the nurse assessor to make sure that there is a proper amount of time that is included in the assessment. So if the assessment says, hey, this is going to take 30 minutes, but actually for your family member, it takes an hour, and I'm just throwing out numbers, so just bear with me. The nurse can actually capture that, and they can add that in into the assessment as well to make sure that the assessment fits the individual needs of each person. So hopefully that gets to your questions. I want to keep moving. Megan, you have and Pat, you still have your hand up, so I don't know if you have more questions.
Yes, just to clarify, you're saying that the nurse can bypass whatever algorithm is attached for minutes for care by putting it in the notes somehow of the assessment so that that person will be allowed more minutes.
So they're not going to bypass the algorithm. What they would do is they would add on to it. And I know Cassie has a lot of information. Maybe she can explain it in a more succinct way. So feel free to jump in, Cassie.
Yeah, so Pat, what would happen is you have this calculation and you have this discussion, and it says it takes I have no idea how long it takes to manage diabetic care. So I'm just going to be very inaccurate and say it takes 2 hours is what the score puts out. But you say, it really, because of having to do supervision and redirection and X, Y, and Z, we need to add an additional 30 minutes. That is not captured in the hourly output that is coming up on the score. There is a section that gives the nurse assessor discretion to say, you know, after all of these components, this really is not capturing X need for redirection or whatever it may be. They have an area in which they can add time that it's kind of a modifier, so to speak, but they have a place to capture that information to say, this tool is missing some components. I don't feel it's sufficient to meet the individual's needs. Let's add that time here. So they absolutely have that discretion.
Okay, so just one more, I'm sorry, but for those people that have family members or individuals who have they have conditions, medical conditions, which require monitoring. And for instance, you know, on a respirator, cannot be left alone, has to have somebody there all the time. How would that be captured?
So I think, you know, if someone has that level of need, they would talk about the level of intervention and frequency of what those needs are, and it should come out to that calculation. So if you're saying it's at all the time basis, it's happening this often, it will get to that 24 kind of hour calculation. It will get there when you're saying this high level of intervention is needing to happen at such a high frequency.
Just so you know, I don't believe that that's the case. I might be mistaken because it's all new to me, but I think that most people that require monitoring, you can't add up the number of incidences where you correct what you're monitoring. So the physical act of clearing a trach tube might take, I don't know, 3 minutes, but the monitoring involved with being present will take, you know, it's all the time. So that is not captured in this tool.
Yeah, so we'll make sure to be monitoring that, but you know, nursing assessment and intervention and care is actually part of the requirement. So we'll have to take that back and make sure that what you are explaining is fully captured and we can identify that particular component of the assessment for you, Pat. But for an individual that needs 24/7 care, the tool is going to calculate and provide 24/7. Our piloting has shown that on individuals. So, but we'll take a look at that. Megan.
So I spent some really fun hours reading through the Telgen contract yesterday. Riveting. But going back to the timeline conversation we had before, I'm concerned about the timeline and getting the assessments done in a timely manner. What I could find in the contract was from when somebody requests or puts in a referral, they have 24 business hours, so 3 days, I assume, to schedule the assessment. No timeline for how long it takes to get the assessment scheduled, and then 48 business hours, so 6 days from when the assessment is done to get the report, which is a lot more than the 7 days that we had, 7 business days we had originally sort of, or that had been thrown out as an idea or a planned piece. And so I'm concerned, you know, I get scheduling the assessment. If the family can't do it,
Right.
It's going to be all over the place. But if there is no standard, like we could call and they say, yeah, we're really backlogged. We just got 1,000 referrals on July 1. So it's going to be September 1st by the time you get the assessment. We're going to have a really big problem.
Yeah, fair. And we can look at that. Like I said, we're going to have the timeline posted and making sure we're walking through that at the next meeting for sure. They have a timeline and a standard that they have to meet. There's some interoperability requirements per CMS. We did not put a specific, you have 2 days to get the assessment scheduled, because what if they can't get a hold of the member? And we can't hold a contractor to a standard that they have no way of meeting. Like if they cannot meet it, we cannot hold them to that standard. And so it gets really messy there, but we will have it outlined very clearly so that it is super abundantly clear that it is not going to be, we call in July and your assessment gets scheduled for September, because that's not a thing. And they will not be allowed to do that.
But if it's not in the contract and it's not in the rules, then what?
We'll point out all the pieces where it will be in contract, and if we need to amend the rules, Megan, you love it when we amend rules, so it will be fine.
Sounds good.
All right, I know that Pat, your hand is still up, but I'm going to keep moving on. Laura, your hand is up, and then I want to move on with the slides so that we have a chance to get through all of those.
Perfect. And I won't take long, just to piggyback a little bit on what Megan is saying. It would be great if we could hold them to like a first contact timeline. We understand scheduling the assessments is
Yeah,
out of their control, but if we could have like you've got to attempt to contact this individual within a certain amount of time frame, that is something that absolutely can be held, because that is something they can control.
yeah, that is in there actually. So we do, and we also have outlined in there how many attempts they're required to make within a specified time frame as well. So
Perfect.
it's, I mean,
So-
it's like you're required to call 3 times in 3 days or 3 times in 2 days. I don't remember exactly what it is, but those timelines are specified in there.
Okay, that was great. That wasn't my question. I just wanted to really quickly point out my concerns around personal hygiene being grouped. I say this a lot. I understand the need to group these together in certain areas and determining times and what they need support in as far as the members needing help with certain tasks. My concern is that each one of those tasks that you're grouping together could be done at a different frequency. And so we got hair care that can be done once a day, mouth care is twice a day, nail care is once a week, shaving could be 3 times a week. And so we're grouping tasks together and asking them to determine the level of care that somebody is needing, and the amount of care that they're needing. And then when we're trying to break it down, and you can even look at like the calculator, it has it broken out in the HMA, but it doesn't have it broken out in PCW. You're asking us to be mathematicians in figuring out a frequency and a how much when we have tasks that are being done at different rates. So I just would like to see if we could maybe revisit that potentially on the calculator. I know the assessment tool can't be adjusted, but as long as case managers understand you can't give us a frequency of hygiene at 3 times a week when we have a task being done twice a day. And so,
Right.
So yeah, it's just, it gets a little icky with the math. So I just wanted to point that out.
Yeah, we can certainly, if there's a certain component within the direct care calculator you want us to look at, we can certainly take a look at that. All right, let's move on in our slide deck so that we have a chance to get through everything. Next slide, please. And Samantha, I see your hand up. We will come back to you. And if you want to type in your question in the chat, we can, there are folks that can take a look at that as well. Thank you very much for your patience. All right. So in summary, the nurse assessor's role is to complete the skilled care acuity assessment and provide a recommendation to the member and the case manager / home health agency if there's a home health agency involved. The process is going to better support members with their skilled care needs. They are going to provide, make sure that they have the services and understand the delivery options that are available to them to meet their unique needs. So the idea is there's going to be education is important so that the individual, the member of the family can understand what are their options. You do not have just one option. You have multiple options. And oftentimes members don't know that they have multiple options. And so this is really to make sure that members have that information on the forefront. And, you know, self-directed options are going to be available and promoted to more people. More people are going to know that this exists. It's really exciting. And it's going to be available to more people with CFC, which we're also very excited about. All right, next slide. Okay, so we're going to run through a couple of case examples here for you all, just to kind of put some context and some actual numbers and situations on paper, if you will, because sometimes it helps us with being able to visualize how this is going to work. So the first one is our good friend Donald Duck. We're really good at coming up with creative names. Donald Duck is 67 and has been using CDASS since 2014. He is vent dependent, quadriplegic, and requires a trained attendant to manage all of his respiratory care and medications, vital sign monitoring, feeding, range of motion, toileting, and then some. So the current CDASS services, Donald Duck receives 6 hours of homemaker, 14 hours of personal care, and 140 hours of HMA, which equals 160 hours total of CDASS services. The nurse assessor goes out and conducts the acuity assessment and determines that Donald Duck actually has a need for 168 hours of private duty nursing weekly. So at that level of care, so that level of intervention is where Donald Duck services are. Next slide, please. So again, the current hours there, 164 hours weekly. The acuity assessment actually assessed for 168. The recommendation here is Donald Duck can actually use the 168 hours per week in PDN, health maintenance activities, or a combination of both. So he can determine how he wants to get his needs met. He can also choose to keep his CDASS hours as is if he would like, which would include some of the unskilled care. So this is completely Donald Duck's decision on how he wants to have his needs met and how he wants his care to look. The authorization, Donald and his case manager decide that they're going to use 168 hours of HMA weekly in CDASS to meet his needs, rather than going down the private duty nursing route, because that is his preference. So the example here shows that there's an assessed need, and Donald Duck gets to determine how he gets his needs met. Next, and we're going to keep going through the examples here real quick. I do see a hand raised. Next example is for Mickey Mouse. Mickey Mouse is a 10-year-old with CP, overnight oxygen dependence, seizures. Mickey needs prompts to bathe, change clothing, take medicine, and reminders to eat slowly. Current service hours are 4 hours per day of CNA and 10 hours per week of homemaker through the CES waiver. The acuity assessment determines that Mickey Mouse needs 2 hours per day of CNA. And then the direct care service calculator. So remember that we have the direct care service calculator also being provided or utilized when there is unskilled services identified in the assessment. The direct care services calculator identifies 21 hours of personal care per day plus 10 hours of homemaker per week as the needs. Next slide, please. Okay, so this goes through the current services that are being received that are currently unparred. Just keep that in mind. There's the acuity assessment recommendation with the direct care calculator. I think that one's broken down per day versus per week. I was like, wait, that's a different number. 3 is different than 21. That's because it's broken down by day. The recommendation of 14 hours of skilled care, 21 hours of personal care, and 10 hours of homemaker per week. I don't think these, oh yeah, it does add up. And then the authorization, so Mickey Mouse's case manager, Pat, these are not real examples, just to be clear. The point is just to show you how some of the calculations and how it could work. Mickey's case manager will transition the services to CFC. The family has decided to go with IHSS for all of Mickey's services. So the personal care and home health maintenance activities will all be provided within IHSS. So these are some examples just to show that the recommendation and the assessment, how it can be molded and fit and put into an authorization to best meet the member's needs based off of the member and the family's choice and how they would like to utilize that recommendation to meet their needs. That is the goal of this, is to show that there are a variety of ways that an individual could actually get their needs met when they have the information, when they know that there are different ways to get their needs met, when they know that there are different delivery options. Okay. Next slide, please. All right, so we have time for some more questions here. I would like to go back. Samantha, do you still, or did you get your question answered in the chat? I know you lowered your hand, probably be kind. I wanted to make sure you had an opportunity to ask.
Thank you. I'm not sure, Erin had said maybe we can't answer it now, but I can double check it.
You can ask it, and if Erin said she's not sure, I probably will have to come back to it too, but that's all right.
So I just want to make sure. So the direct care calculator, the interim one, we should be starting to use May 1st for July 1st and July and August.
Correct.
Start dates. Is that correct?
Yes.
And we also would be using it starting May 1st for those unskilled homemaking and personal care services.
Yes, because you can start reviewing for a July 1 start date for CFC starting in May.
Okay.
And those services would be authorized within CFC.
And we would still, because I think you guys had said like business as usual, but that is a pretty big change using that new calculator.
Okay, I see the discrepancy is currently going through. So that is a CFC process question that I understand your question, and let us confirm and bring that back to you to make sure we're 100% all on the same page. The business as usual that we've been referring to is the health maintenance activities, how it goes through intelligent to ensure that is the piece that doesn't change. But your question is more specific to the direct care calculator for the unskilled tasks, and if we are utilizing that now.
And with IHSS and CDASS as well.
Yes. So really what we have done is try to make things easier. Feel like maybe we've made it more difficult, but we took the IHSS care calculator and the CDASS task worksheet. We've merged them together into the direct care calculator. That's going to be used effective May 1st. Because we had to figure out how to begin that authorization of HMA during this period, we have HMA added to that direct care services calculator that will be used by case managers in authorizing HMA for May and June. So you'll be using this new tool beginning May 1st for those certifications in July and August. With that use of the tool, you'll also be utilizing the existing HMA process, utilizing Telligent to review that. So you'll be just using this new version of the tool, which is built into the bridge through May and June. And then you'll still use that past June and July if you need to use it for personal care and homemaker services outside of the need for skilled services. Hopefully that makes sense.
And you'll still need a matching provider plan of care if it's IHSS, correct?
Yes.
Okay. Thank you. I appreciate it.
Thank you, Cassie, and thank you, Samantha, for that question. We have another hand raised, H. Sanders.
Hi, yeah. So my question is in regards to, let's say you have a kid who qualifies for 168 hours of the PDN. So you've got 24/7 hour care. It can be PDN, HMA, any of those skilled needs. Let's say that, like for us example, we had a nurse for 40 hours a week, and nurse up and left very quickly. How easily are those 168 hours that can be used either way? Are they standing and open so that we can quickly reabsorb those under HMA, or do we have to have reassessments? How does that process work?
So great question. So as long as there isn't a change in the condition for the individual, so they haven't had a change in their actual care needs, the recommendation lasts and it stands for a year. So it's an annual. So if you have to make a change because of staffing concerns, or let's just say HMA isn't working out. It turns out that we tried this, we didn't like it. We want to go back to traditional agency-based care. You can make that shift. You just have to work closely with the case manager on that, but that can happen. You do not need a new recommendation. You do not need a new assessment.
Okay, so let's say, like currently, for example, we had the 40 hours of PDN and then the 128 hours of IHSS. And then let's say nurse calls in for 2 days a week. We're still stuck at those 128. Like we can't just quickly pick those up. Will that change?
Cassie, did you want to jump in?
No, I was gonna for afterwards.
Looks like Erin wants to jump in.
Hi, this is Erin. First of all, I will say we know this happens. Like it's a reality where like we have a staffing issue and someone can't fill in. We cannot fill in PDN hours with IHSS. And we know that that's happening for a lot of folks just because of staffing. What I would say is making sure that you have a backup plan with each agency for scheduled visits. For IHSS, agencies are required to provide backup care for scheduled visits. Should be the same for PDN. That said, as long as you have services both authorized, like you're on a waiver with or in CFC with IHSS and you have PDN, it's easier to like end date one service and add hours to the other. It's pretty streamlined. I will say on the home health side, for PDN, there's a medical necessity review and some other, there's a lot more documentation required for the PDN side versus in IHSS. So if you have both on the letter and you know, it makes sense to go all in on HMA, you're more than welcome to do that with your case manager. They can revise the PAR pretty quickly.
Okay, thank you.
Thanks, Erin. All right. Cassie, you have your hand raised.
I do. I saw this trend a couple places in the chat. So let's take the example of there's a greater than 5% variance in what I'm currently authorized and what the tool comes up with.
Mhm.
I work with my case manager. How does the case manager have the authority? What skills, what information is required for them to be able to, with authority, say, yes, it is acceptable to add 10 more hours a week of services to your service plan? How do they go about doing it? Does it need to go back to Telligent? And then if they're not going to make a change to the PAR based on facts, what then does the case manager need to do?
Sure. Okay. So for the first assessment around, or for the first question around how do they have the authority, case managers have the authority to provide authorization. They do the prior authorization. That is part of their contract. That is part of what they do and the work that they do. If and the reason why they will know is because they have ongoing conversations with members. It is they still do the ULTC 100.2 until we get to the CSA. They're still conducting the level of care assessment. They are still conducting service planning. They're still meeting with the member to understand the full breadth of their needs. And they're going to have a conversation with the member of, hey, you're authorized for 10 hours. And the member says, that's not going to be enough. And here's why. And they can provide concrete examples of, you know, actually, it takes me a full hour to do X, Y, and Z. And I have to do it this many days a week. And, you know, so the case manager can get those examples and they just document it within the assessment, within the level of care assessment, or within the case notes. I'm not sure if they're called case notes in the CCM, but they document it within the member's record as to why they are authorizing the additional hours based off of the member's needs. So it's that simple. It will not need to go back to Telligent. There is no, this is the beauty of the change is current state, there is a lot of back and forth with Telligent. Future state, there will not be that back and forth. That is not going to exist. You do not then have to send it back to them for review in any way, shape, or form. You can just authorize it. If you get the recommendation and after conversations with the member, you determine the recommendation is actually accurate and there is no justification for the additional hours, maybe it's a just in case something happens or a just in case, which is not something that is traditionally authorized, then the case manager would actually issue the 803 notice for a reduction in services, just like they do now. What other questions do we have? Erin.
I wanted to see if we could get some clarification on documentation. Because we're in self-direction, we're talking about health maintenance activities. Documentation is a lot different than what currently exists in private duty nursing and long-term home health. Is there any way that you could go over what that looks like for this population and these assessments? And
Erin, would you like to talk through all of that? You're the documentation queen. And, you know, we do not require physician's orders and things like that to get the assessment for any of these services. You know, there is obviously a physician order that is required in order to receive private duty nursing or long-term home health, but it is not required for health maintenance activities. So I'm going to let Erin outline the documentation. And I will just add before she gets going, documentation is helpful. It's always helpful if it exists, but it is not required. Now I cue Erin.
Okay, thank you. Hi, everybody. I think that, you know, if I think about health maintenance activities and how different they are in terms of the service delivery, the main difference is that we don't require documentation on how services are provided. So in the traditional model, if you need nursing services, you need to get a doctor's order. The nurse at a home healthcare agency would come visit you, and then they do a prescribe and treat, and they develop a 485, and the 485 would be sent to the doctor to get a signature for the activities that the caregiver is going to help with. In HMA, we don't have that. And because we waived the Nurse Practice Act, we're not requiring our attendants to be certified or licensed. They need to be trained and they need to be able to do the skilled tasks on the assessment or as indicated in the assessment. But in terms of documentation, I think it's really important to note that documentation is really not required. What we do want is for case managers to effectively document that a person has a certain need, and they can do that in their assessment. And then if you happen to have things like, I don't know, a seizure action plan or an asthma plan or a sliding scale diabetes plan, if those exist and you have them, you could provide them to the nurse assessor to help demonstrate like what is happening. But we don't need to go into this thinking like you have to prove why you have an oxygen concentrator at your house. Like we have it because it's been ordered and because we do this for respiratory care. So I say this just to kind of level the playing field a little bit between what the traditional home health and traditional PDN, private duty nursing, looks like. It looks different in IHSS and CDASS, and we don't want to change that at all. We want members and their authorized representatives to direct their care and to be able to be in that conversation driving what they want care to look like with the appropriate tasks. And I think the other one thing I did see here in the chat kind of related to documentation was like, if we can't do assessment in HMA and that's part of the acuity assessment, what do we do then? Actually, you can take the assessment parts out of the acuity assessment and still get 24-hour care for people who are ventilator dependent, who have very high needs. So there's a lot of flexibility built in, and ideally we want to be able to demonstrate through the assessment and the acuity tool what the needs are, and get those needs approved. And if they change, be able to affect change pretty quickly. So anything I missed, Candace?
I don't think so, but I saw a bunch of hands go up while you were talking. So if you could stay on, we're going to answer a few questions and then we'll move on to the rest of the slides because we are almost out of time. Looks like Pikes Peak Home Care. You have your hand raised.
Okay, can you hear me?
We can.
Perfect. Okay, so I just kind of wanted to make sure that I sort of understood how this nurse assessor process is going to work. So the client who expects to need HMA hours will get a referral. There will be the nurse assessment in which the acuity tool, from what I'm trying to make sure, is more of like a starting guideline of hours, in which case after there is a total produced by that, the client, the nurse, and the case manager will then communicate the finer details to find the final total of hours that will meet the client's needs, correct?
I wouldn't say it's a starting point. I would say for most members, it's going to be the totality of the needs outlined in the tool. The tool is pretty comprehensive and will outline the needs. The idea of the communication and the piece on the back end is if the case manager or the member finds that the tool and the hours that are recommended don't meet their needs, or if the nurse in conversations during the assessment realizes that it's not going to meet their needs, then there is that opportunity to add the additional hours.
Okay, that's perfect. That was exactly my question. Thank you.
Yeah, of course. Megan.
Okay, so in your Donald Duck example, he qualifies for more than 24 hours a day of combo of services between homemaker and HMA or PDN. So my question that comes from that is, for homemaker, does the member A have to be home, or can homemaker be performed while a different provider's there performing different cares? And I hesitate to ask that question because if you say the member has to be home for homemaker, then ignore my question and let's pretend we never did this whole thing. But I'm assuming if he can qualify for more than 24 hours, we're acknowledging that homemaker is sort of a separate from member type task.
Yeah, it would be separate. And so they certainly could be provided while another type of care is being authorized. I'll look to Aaron around the homemaker if they have to be at home.
I'm going to say it depends. So Megan, it depends on who your employer is. So yeah.
From a point of view, no, but if your agency says yes, then yes.
Yes. And also I think there need to be like a reason associated, like, the member can't be home because of this, so we're going to have this done while they're gone.
Got it. That makes sense. My other piece is I still am struggling. Like I went through this skilled assessment for my kiddos and I came out with these 3 different numbers on each of the 3 tabs, and I still can't figure out how to combine those together into an HMA number. And so maybe when we do the recommendation letter meeting, that will become clear, but I can't connect the 2 dots.
We can certainly take that back and figure out how we can better outline how we can connect those dots, if you will, for sure. Thank you for that feedback. All right, we have time for really one more question. And Jessica, you've had your hand raised for a little while. Deborah, if you don't mind typing your question into the chat so that we can capture it and hopefully get back to it in our listening log, because we have just a couple more slides that need to get through and we're almost out of time. Go ahead, Jessica.
Hi, sorry if you hear kids in the back.
All good.
Just quick questions. If let's say your physical therapist for your child has ordered orthotics, does that fall under that health maintenance category of like maintaining and managing braces?
Yes.
Okay.
Yes.
All right. Second question is, under the nurse assessor, I see a lot of, if the client is unable to verbalize and, I have a nonverbal son, where does that fall in that health maintenance part? Because if he can't verbally or in any nonverbal way communicate his needs to me, I have to basically be watching him the whole time. If he's got a poopy diaper, he can't tell me. If he stubbed his toe or has a thorn in his foot, he can't tell me. So I'm trying to figure out how to score all these things, considering that he is unable to communicate any needs to me.
Erin, did you want to jump in on that?
Yep, for the skill care acuity assessment, you'd want to look at the modifiers. So there's ones for communication, expressive and receptive, and then cooperation. So that will help kind of provide that context. And then if we're talking the direct care services calculator, age appropriate guidelines is going to be the best bet. And if someone needs above age appropriate support, then they'll qualify for those services typically.
Thank you, Erin. All right, we are going to move on to the next slide, please, because we have 1 minute left. Okay, so just a timeline for everybody to see. We are currently in the month of April, but just barely. And so next month we are going to be working on training for the assessment for the vendor. In June, there is another stakeholder engagement meeting that we didn't list there. My apologies. In June, we are going to be training for stakeholders on the assessment and the nurse assessor process, and then additional systems preparations. And then July, we are launching, which is really exciting. Next slide, please. All right, next meeting is May 13th from 10:30 to 12. Please mark it on your calendars. As you guys brought up some really great points and additional things for us to make sure that we cover next meeting. Additionally, we're going to be seeking very specific feedback around the expedited process and what that looks like and the criteria for it, and then also the criteria for in-home, so in-person versus virtual assessments. And so we want your opinion, we want your feedback, we want your guidance on how we create that criteria and what that criteria looks like for our vendors. So please come to that meeting to provide that. Next slide, please. All right, so just as a reminder, there were a lot of chat questions. There was a lot of information in the chat, and my sincere apologies. We have no way of getting to every single thing. We do capture every single question and every single comment that comes through the chat, and we will be posting it online via our listening log as we do for all previous meetings. We will get that every single question answered and posted and up on our nurse assessor website as well. Any additional questions that you might have, please send them to the home health inbox, homehealth@state.co.us, and then there is the link for the nurse assessor website. Thank you so much for your time, for your 90 minutes on this almost end of April. We really appreciate your engagement. We really appreciate your time and your willingness to come and ask these wonderful questions. Thank you all so much. I hope you have an excellent day. Take care.